I'm Megan Petroselli. I'm a nurse in the emergency room and in the pediatrician's office.
And I'm Christine Van Lee. I'm the nurse manager of maternity and NICU at Lawrence Memorial Hospital. We will be discussing our article, Wait, Don't Rush the Bath, Delayed Immersion, that we are submitting to the Journal of Perinatalology next week. We're very excited.
All right, just briefly, the overview, we're going to talk about the description of our project, a brief overview literature review, the problem that we faced, why we did this project, the approach to our project, the outcomes, the implementation for practice, and what we found in our conclusions.
All right, so a brief description of our project. Initial bathing of a newborn is a very important experience for both the mom and the baby and the dad. The benefits of delayed immersion bathing are decreasing hypothermia, increasing parental satisfaction, and promoting breastfeeding. In 2012, the Association of Women's Health and Neonatal Nurses changed their recommendation with regards to newborn bathing. They publicized a statement supporting delaying the newborn bath. Research supported the Wait for 8 campaign, which also discussed the many benefits of immersion bathing. The benefits include, as I said, thermoregulation, increased parental interaction and satisfaction, and increased breastfeeding rates. Currently in Connecticut, many hospitals practice delayed bathing, but very few, maybe two, have implemented the delayed immersion bathing technique. In January 2018, L&M initiated the delayed bathing process. We identified newborns who have not been bathed yet with a duck on their crib to let the staff and visitors know that they have not had their bath yet and to use proper protective equipment. Last August, as part of our evidence-based practice project, we initialed a trial of delayed immersion bathing at L&M's 24-bed unit.
All right, so we looked at the literature to see what was supportive of this best practice recommendation. We didn't just take their word for it. So best practice recommendations show the benefit of delayed immersion bathing as improved thermal regulation, improved breastfeeding rates, and improved patient experience and satisfaction. So the literature that we found is very supportive of it. One study we looked at was by Prior. They demonstrated that there's an improved temperature regulation, decreased hypothermia, and an improved skin-to-skin contact, which led to increased breastfeeding rates amongst the newborns, which eventually was increased parental satisfaction. Brogan et al. Also demonstrated that immersion bathing increased newborn temperature stability, increased parental satisfaction, decreased hypoglycemia, and allowed for more parental involvement with the first bath. We also looked at a study which discussed the vernix, the white cheesy stuff that is on the baby, which used to be wiped right off, that used to be thought of as dirty. However, there's a study that shows that it has antimicrobial properties, which is used to help protect the skin, which show it's actually a benefit to leave it on the skin. There was also another study by Saucy et al., which showed that increased parental satisfaction and breastfeeding rates came from the delayed immersion bathing. And the opportunities were there for parental bonding because of this. So there were random controlled studies, there were quantitative and qualitative studies, and evidence-based practice studies that we looked at that were all supportive of this initiative. There wasn't much literature that was against any of this. So why did we do this project? When we first started the project, there were few, if any, actually there was only one hospital that was doing this trial of this technique. Since we started the project, another hospital in Connecticut has started it. In 2001, A1 had started the recommendation, so that has been a long time coming that we started to implement the evidence-based practice into our actual practice change. So the current practice on the unit is the delayed for 8 sponge bathing technique, which was the A1's previous recommendation for practice. So we wanted to look at implementing the best practice recommendations onto the unit. So we looked at a trial intervention using the recommendations of delayed immersion tub bathing to see if we could align it. We wanted to evaluate if the implementation would support the best practice outcome claims. We wanted to identify if immersion bathing would currently work on our unit and identify if there are any barriers, if any, that would prevent this from being a success and work on with our current unit staff.
So the approach we took is we need to gather some data to prove that the research was all correct and to kind of show it to the staff. So starting in July and August, I held staff meetings to disseminate articles and to review a previous PowerPoint that we used to educate staff during our delayed bathing rollout last January that briefly skimmed over the immersion bathing. Megan and I planned meetings with Kathy Mason, who's our lactation consultant and our biggest champion, management, which is me, Donna Nucci, our infection prevention colleague. We had meetings with supply chain, bedside nurses, and identified nurse champions on each shift. Temperature logs were created and staff gathered data pre and post bath. Parental satisfactions were handed out to the week prior to our implementation and the week of our trial. And Kathy Mason did a retrospective gathering of data to get our breastfeeding rates for us. And Megan and I collected the data, we analyzed it, and we shared it with the staff.
All right, so as you can see, the evidence is clear. So the newborns, after the immersion bath, our newborns are dried. They were placed skin-to-skin contact with the mother for approximately an hour. It increased the newborn's body temperature and allowed for bonding and opportunities for the babies to breastfeed. The mothers actually loved it, and there's a lot of really great feedback from it. The newborns in our trial experienced less risk of hypothermia. They had their temperatures, their decrease in temperatures was reduced. There was less hypothermia. The parental satisfaction survey results increased throughout this. What did surprise us, though, is that we were unable to support increased breastfeeding rates. Our study, it was pretty much flat. There was no change in breastfeeding rates. Our theory behind this is that Al-Anon is already a very strong baby-friendly hospital, so the attendance is very high and strong already, so there wasn't really much room for improvement and increased rates to begin with. So that is our hypothesis for why that didn't change.
So what are the implications? The results of our evidence-based intervention are supportive of best practice guidelines. It is supportive, and all of our evidence and interventions clearly supports it, that there should be a change in practice to not only delay newborn bathing, but to include immersion bathing. We did experience some challenges, some we were kind of prepared for and some we were surprised about. As we're ready to roll out this new project as a practice change, this past fall a question was asked from the staff about cleaning the tubs. So we again tapped into our infection prevention resources, and they suggested that we clean the tub with a PDI wipe and then use soap and water to clean it after we do it with the PDI wipe to prevent any chemicals from actually reaching the baby. We also decided we're going to use a plastic covering of the tub in between each patient use to reduce the chance of infection. So there are still some more questions pertaining to single-use items, which our system is going towards. So we reached out to our supply chain again about getting pink basins to use with each baby. The only problem that we have with that is some of our babies are too big to fit into the pink basins. That's why we tried to pick a tub of that size. In addition, the American College of Obstetricians and Gynecologists recommends dry cord care. So we looked at our evidence and we were collecting our articles, and there's nowhere that it says that in our nursing research. The doctors who had collected some of the articles, most of their infections were from low-income, low-resource other countries, very few in America. The chances are really, really tiny. So we did just had a pretty robust conversation at our Pediatric Quality Council last month, and we're going to be continuing that conversation this month. The last issue we had was staff buy-in. So they had two other issues with that. They felt that they were being asked to do a little bit more work because they had to spend more time with the parents during the bath to actually support them and give the baby a bath, and trying to remind them to keep the baby under 5 minutes. They want the vernix to be on the baby, and just a quick wash the hair, wash the face, give it a quick, and then to clean the tub afterwards was time consuming. They had questions about teaching an immersion bath and then actually having the parents do a sponge bath as directed by the pediatricians when they go home. All valid questions, and we're hoping to get those answers resolved very shortly in our next pediatric meeting or two.
So overall, we decided this project was very successful. We accomplished our goals. We are looking to resolve the issues that we just identified, and our goal is to move forward and implement this hopefully on our unit once we resolve these issues. So thank you for listening to our presentation.
Thank you.